All right, hello everyone and welcome to the Graduate College Lunch and Learn series. My name is Britt Paris and I'm one of the executive co-chairs of the Graduate College, and I'm going to be the moderator for today's session. So before we get started, just a quick couple of housekeeping items. So we're going to have two 20-minute presentations followed by a question and answer at the end. As I said, we're recording today's session, but your videos names will not appear on the recording. It is our first time using this webinar platform. So do you have any questions? Feel free to use the Q&A button. You can also post them in the chat. Before we get started, I'd like to take the opportunity to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations. City of Calgary is also home to Métis Nation of Alberta Region 3. We take time to acknowledge where we are as it grounds our work and what we're doing and what we're talking about, and also allows us to consider the space and time and place that we're in as we conduct our academic work. So for those of you who are not familiar with the Graduate College Lunch and Learn series or new to our webinars, they're aimed at emerging scholars with a wider engaging scholars, with the wider Calgary community. These are public presentations that are aimed to bridge that gap. We've been hosting them once a month between April to August. We have one more coming up in August, and they will continue into the fall. I'm excited to announce, so stay tuned for more information on that. And this is a great place for graduate scholars who are part of the Graduate College to present their diverse research for the public. It's a really great opportunity to hear about what they're up to. So our two presentations today are from Julia Daun. She's going to speak to the role of exercise in head and neck cancer care, and Valeriya Volkova, who's going to speak about the dancer as an artistic athlete. How does dance training contribute to injury risk? So these are very exciting presentations. I'm really looking forward to what they have to say. And again, if at any time you have questions for either of the presenter, you can type them into the Q&A box that's under in the control panel for you, and we'll save them for the Q&A period at the end of the session. So we'll hear from both speakers, and then we'll go on to the Q&A. All right, so at this time, I'm going to turn it over to our first speaker, Julia. If you want to go ahead and share your screen.
Thank you, Britt. Can everybody hear me okay and see my screen okay? Excellent. Thank you, Britt, for that introduction. Again, my name is Julia Daun, and I am a graduate student in the Health and Wellness Lab in the Faculty of Kinesiology here at the University of Calgary. And I am also a clinical exercise physiologist, and I've been working in this area of exercise oncology for the last 6 years. And I'm very excited to share a little bit about my work and the work we do in our lab with you today. It's all about exercise and supporting participants and cancer survivors in their wellness through movement and physical activity. And today specifically, we'll be talking about the role of exercise in head and neck cancer surgical care. So after today, I'm hoping that we can all leave with a little bit of a better understanding of the role of exercise for these patient populations. So exercise in head and neck cancer patients specifically. Learn a little bit about the initial work that's being done with this population. And then what are the next steps? So now that we've done some of this research, how can we continue to support these patients through their wellness and into their survivorship? The Head and Neck Cancer Exercise Team here in Calgary is a collaboration between the Health and Wellness Lab, directed by Dr. Nicole Kulos-Reed in the Faculty of Kinesiology, and the Olson Research Initiative, directed by Dr. Joseph Dort over in the Cummings School of Medicine. This collaboration is essentially a number of collaborators, such as graduate students like myself, postdoctoral scholars, clinicians, and researchers who are truly passionate and dedicated to improving the quality of care in head and neck cancer patients. So before we dive right in, I'd like to talk about a few important terms that I'll be referring to throughout today's presentation. The first one being cancer survivor, which is from the point of diagnosis onward. So a person who's been diagnosed with cancer onward. Physical activity, which is defined as any bodily movement produced by skeletal muscle that results in energy expenditure. And exercise, which is a subset of physical activity and defined as a planned, structured, or repetitive bodily movement, often to improve or maintain one or more components of one's fitness. And lastly, movement, which is simply not being sedentary. The idea of just simply moving more in your daily life. Head and neck cancer is the 7th most commonly diagnosed cancer globally, and it includes cancers of the middle ear, nose, mouth, and throat regions. Treatment for head and neck cancer is multimodal, meaning that it includes multiple methods, and it often includes surgery with free flap reconstruction. Free flap reconstruction is when the tumor or benign disease is resected and next replaced with another vascularized tissue from the body, known as your free flap, and it often comes from a bone in either your leg or your forearm. Due to the location of these tumors and the need for this complex surgery, patients often experience high symptom burden. And some of these symptoms include physical and psychosocial changes, such as impairments to being able to speak and swallow, and neck and shoulder dysfunction, and also an increased depression and anxiety and decreased quality of life. Head and neck cancer patients also comprise an underserved clinical population, and they lack access to the resources that may help them improve some of these physical and psychosocial outcomes. This creates a gap in head and neck cancer patient care. In an effort to bridge this gap, the enhanced recovery after surgery protocols were developed to optimize both intra and post-operative care. However, a gap in patient care remains, and that is the lack of pre-operative care and focus on associated patient outcomes. Exercise rehabilitation therefore presents as an opportunity to further bridge this gap. Exercise is an evidence-based tool used widely in the area of oncology to enhance both the physical and psychosocial well-being of cancer survivors. Rehabilitation is an intervention designed to take place prior to surgery to optimize the physical and psychosocial functioning of patients, thereby improving how they tolerate surgery and facilitating their recovery. Exercise in head and neck cancer has been shown to be safe, feasible, and beneficial. A wide range of studies exploring exercise during and after chemo and radiation therapy have been shown to be feasible and effective. And while these studies have included surgical patients, no study to date has looked at exercise prior to surgery. Correspondingly, rehabilitation has a growing body of evidence, and it has been examined in a number of tumor groups, such as lung, pancreatic, colorectal, renal, prostate, and breast. And it has the potential to optimize patient care and outcomes. However, it has not yet been studied in head and neck cancer. While there is this growing body of evidence pointing to how rehabilitation is feasible in other tumor groups, it doesn't necessarily mean that what worked in prostate or renal will translate over to head and neck cancer. Given the head and neck cancer patient population is a complex population, we must consider the important unique factors prior to implementing an exercise rehabilitation trial. Patient-reported outcomes, physical function, and mobilization are all important components of an exercise prehab trial. Patient-reported outcomes include things like one's quality of life, depression, anxiety, fatigue, and symptom burden. And these are self-reported by the participant or the survivor themselves. Physical function include things like one's aerobic fitness, muscular endurance, and strength. As an example, being able to get up and down from a chair. And then mobilization in the context of in-hospital mobilization refers to getting the patient out and moving out of their hospital bed. What we need to understand is which of these measures and at which time points will be acceptable and feasible for head and neck cancer surgical patients. The purpose of my master's work and what we've done so far in head and neck cancer care and exercise was to really understand and examine the feasibility of implementing these measures across this clinical timeline for these patients. And then 2, examine the perceptions of both patients and healthcare providers on implementing exercise into the clinical care pathway. By understanding the feasibility from both a quantitative and qualitative perspective, we're able to understand a more comprehensive level of what patients actually need, what they want, and how it makes sense in the clinical setting. So let's talk a little bit about what this head and neck cancer surgical timeline or surgical trajectory actually looks like. Prior to surgery, patients often have about a 25 plus or minus 19-day waiting period from the time that they agree to their surgery, so they sign their consent, to the time that they actually make it into their operating room. This is often a very overwhelming time for patients. They next go into their surgery and then they're in hospital for about 10 to 14 days afterwards. This depends on a number of factors such as their health status prior to surgery, any complications that may arise from surgery, and things along those lines. At about 6 weeks post-surgery, approximately 1/3 of patients will begin adjuvant therapy, and that's your chemotherapy and your radiation therapy. So what we did along this clinical timeline was collect information on patient-reported outcomes via electronic data capture. So what that means is patients were completing questionnaires and surveys through their iPads or their computers at home and in hospital. We collected physical function measures via in-person assessments at the University of Calgary and in hospital. And then we tracked their in-hospital mobilization through the use of an activity tracker. These measures took place across that clinical timeline that we just looked at. And assessments were prior to surgery, in hospital 10 to 14 days after surgery, right before they discharged, and approximately 6 plus or minus 2 weeks after surgery. We also conducted interviews with patients and healthcare providers. Interviews with patients took place both in hospital and at the 6-week time point, and interviews with healthcare providers took place towards the end of the study once clinical workflows had been established. A few of our key findings included that referring patients was found to be feasible. Healthcare providers, surgeons, and the clinical team were willing and able to refer patients into our study. In fact, we achieved a 100% referral rate throughout our study, meaning that when we had eligible patients, 100% of them were referred to us by their healthcare provider, which is fantastic. We also found that measuring patient-reported outcomes was feasible across that entire timeline. And in-hospital mobilization was also acceptable and feasible. Physical function, although it was feasible in hospital and at the 6-week time point, wasn't feasible prior to surgery. We'll talk about that as well in a few minutes. Patients and healthcare providers were in favor of exercise as part of the head and neck cancer surgical pathway. Importantly, through our interviews, we were able to find that patients found that measuring their outcomes and their physical function was acceptable and necessary, and actually it provided them with a benchmark to which they can refer back to throughout their recovery. Interviewing the clinical team was super important as we were able to understand what logistics look like in the clinical setting. Healthcare providers are already very busy trying to juggle all the priorities that the patients need. And so it's important that before we go and add in additional measures and additional pieces to their workload, that it's actually going to make sense for them and not be burdensome. As a result of working with the clinical team, we were able to successfully adapt clinical workflow, meaning that at the time of surgical consult, we're able to implement new practices so that we can get referrals. And at the time of the in-hospital period, so that patients can actually receive their activity tracker through their healthcare provider. So adapting workflow so that when the patient arrives on the unit after their surgery, their nurse or their clinical team is able to provide them with that watch. Based on the results from the study, we're able to make a few important recommendations for a future exercise rehabilitation program. First, we know that patient-reported outcomes, completing them across the clinical timeline was feasible at each of the time points. However, physical function was only feasible in hospital and 6 weeks post-surgery. So instead of asking a patient to come in prior to their surgery for an assessment of physical function, we need to explore some other options. After all, it's all about supporting patients and their wellness. And if we're going to be adding on to their care pathway, we want to make sure that what we're adding is actually complementary to what they're already receiving. For some of our patients who are out of town, or even those who live in town, there's a lot of pre-operative appointments, a lot of driving back and forth from the hospital and home, and a lot of physical and psychosocial trauma that happens in this time. Imagine that you've just been told you have cancer and that you require this major surgery with months of recovery. And now we're asking you to come in for additional appointments and additional preparation pieces prior to your surgery. The last thing we want to do is overwhelm the patient with more assessments and more appointments. Therefore, the pre-surgical timeline, that time frame of about 25 days on average for our patients, should therefore include more general movement prescriptions as opposed to an assessment and a structured exercise program. In hospital, we know that these measures were feasible and acceptable. And in hospital, also, our exercise prescriptions can become a little bit more structured and the exercise specialist that would work with patients in hospital can begin to recommend pieces of exercise and movement that can help them start to rehabilitate and recover. Of course, working with the clinical team and physiatrists and physiotherapists and other people who are part of this movement kind of protocol. Interestingly, we also found in our interviews that patients felt a little bit left in the dark when they were leaving the hospital. Although they are provided with nutritional counseling and support and education on what to expect across this timeline, they felt that more education on how they can begin to return back to their normal lives would be complementary. So including an education package on nutrition, movement, and social support and psychosocial support throughout that timeline would be recommended to support them as they transition into recovery. Lastly, at the 6-week post-surgery time point, we can continue to measure their patient-reported outcomes and their physical function. But importantly at this point, we want to ensure that our patients can feel supported into the long term. So how do we foster long-term exercisers or people who engage in physical activity long-term? We know that from this behavior change and psychology perspective, that social support is a huge factor when it comes to exercise adherence. So therefore, transitioning patients into a community-based exercise program that's evidence-based and already well-established will be key for fostering their long-term wellness. Most importantly, across this entire prehab program, it needs to be individualized and tailored to each individual. So let's explore a little bit as to what I mean by that. First, it's important that we consider the participants or the survivors' current activity level. How much are they doing? What are they doing? Are they engaging in more aerobic type movements like walking or running? Are they engaging in more resistance type movements like squats or sitting up and down from a chair? Are these people already active, or maybe they lead a more sedentary life? So it's important that the exercise specialist and the team behind this, developing this movement prescription, is aware of how much they're already doing, so that the prescriptions and recommendations that are given are complementary and not overwhelming. Second, it's important to consider what the participant or the survivor actually enjoys doing. Again, from a behavior change and psychology perspective, we know that as soon as we give someone the power and the empowerment and the decision to choose things that they actually enjoy doing, we see better adherence long term. So understanding what the patient's preferences are. Do they like gardening or walking, or maybe it's swimming? Maybe it is structured exercise in a gym, or maybe the gym is the last place they'd like to step foot into. So really understanding what do they enjoy doing and making recommendations based on that. It's also important to consider one's barriers and facilitators. So obstacles, and then things that help them get over those obstacles. Interestingly, the #1 most reported barrier for all of us is time. So now let's add on a cancer diagnosis and a very time-consuming pre-surgical timeline where there's a number of appointments. People are trying to figure out arrangements at work, trying to figure out what their schedule is going to look like over the next few years. Let's say they're already not exercising, and here we are asking them to add in more movement. So considering what their barriers are, what are their obstacles, and how can we provide them with support so that they can get over those obstacles and eventually become more active and move more in their daily life. As an example, one's facilitator is social support, so always coming back to this idea of finding someone that can help support you in your exercise journey. And that can come in the form of many different things. It can be an animal or a dog, it can be your spouse, a family member, or a friend. Finding someone that can help you in this process, either by getting directly active with you or maybe supporting you via phone calls, is a great way to work through some of those obstacles. Next, we have accessibility. So understanding, what do these participants have accessible to them? Maybe they live right across the street from a YMCA or near a park, or maybe they have access to water nearby or a pool where they can go and be active, or maybe there's tennis courts nearby, or maybe they live in a more rural or remote area and don't necessarily have access to these types of things. So understanding what resources do these participants and survivors already have, and how can we work with what they have so that they don't feel burdened to have to go and buy expensive equipment or buy a gym membership. What do they have to work with, and how can we provide them with prescriptions based on what they already have? And lastly, we must consider their overall health status. So coming into the surgery, where are they in terms of their health? What are their lifestyle pieces? What is their nutrition like? Coming back again to how much movement they're getting. What other underlying health conditions do they have? A lot of these patients in head and neck cancer are frail to begin with. So understanding what their health is prior to adding more movement or changing their movement prescription that they already might be engaging in. At the end of the day, it's all about supporting patients in their wellness, and we want to do that through movement. We've talked a lot about exercise and physical activity and how that structured aspect can be really important to help starting to get patients to rehabilitate the muscles and pieces of their body that may have been disturbed during surgery. But after all, it's all about movement, moving more in a way that feels good for the survivor. It doesn't have to be structured to count. It doesn't have to be done in a gym to count. And it doesn't have to be 1 hour every day to count. Sometimes smaller bouts of 5 or 10 minutes added up counts. It all adds up. And so it's about supporting people in their movement in any way that works for them. This study was the first to explore feasibility of exercise prehab in head and neck cancer. Because we were able to interview patients and healthcare providers throughout this process, we were able to explore multiple perspectives of key user groups involved in head and neck cancer care. As a result from working with the clinical team, we were also able to adapt workflow, which when implementing something into the clinical setting can be a challenge. And ultimately, what this study does is lay the foundation for future work in exercise rehabilitation for head and neck cancer surgical patients. I would like to leave you with a few final thoughts. Through our interviews, we gained a number of very valuable perspectives and feedback from both patients and healthcare providers on what we had done in our study and what they would like this future program to look like. And I have 2 quotes that I'm about to present with you today that I feel really resonate with me and really convey the message of how important movement, physical activity, or exercise is for patients and healthcare providers. As an example, one of our patients found that the only reason why they were able to survive their cancer the first time was because they were fit enough to be able to do it. They say, how many people usually survive stage 4? Usually that's a death sentence. Our healthcare providers had very similar thoughts. One of them actually said that exercise is priceless and that it can't be overstated how valuable it is. Having seen so many patients over so many years, the ones that move feel better, recover better, and just feel more alive. They just do better. And so they think that exercise is very, very important. What I think is important to take from these 2 quotes is that both patients and healthcare providers found value in exercise and movement throughout this clinical timeline, not only to support them in their recovery and in their journey of cancer, but into their overall health and wellness after their diagnosis. None of this would have been possible without a number of very key individuals, such as my supervisor, Dr. Nicole Koulos-Reed, my incredible committee, comprised of Drs. Joseph Dort, Dr. Loren Kaposi, Dr. Rosie Toomey, and Dr. Linda Watson. Our and my funding sources, the Olson Research Initiative, the Alberta Innovates Health Solutions, Training and Research, Clinical Trials, and Integrative Oncology Traction Program, and the faculties of Kinesiology and Graduate Studies. And of course, the amazing participants that were part of the study who gave themselves so selflessly so that we can advance the care for head and neck cancer surgical patients. If you'd like to get in touch, my email is here on the slide and my Twitter. And if you'd like to read a little bit more about what our lab does and the resources we have available for cancer patients and survivors, you can follow that website on the slide as well. And I just wanted to say thank you all for having me here today. I truly enjoyed sharing my passion and a small snippet of the work that we do in the Health and Wellness Lab. And I hope that I can encourage you all to move a little bit more and understand the role of exercise for the cancer patients, specifically head and neck cancer patient population moving forward. Thank you so much.
All right, thanks, Julia. I'm just gonna go ahead and share my screen and we'll switch gears a little bit for my presentation here. So as Britt mentioned, my name is Valeriya Volkova and I'm a PhD candidate in the Faculty of Kinesiology, and I'm working out of the Sport Injury Prevention Research Center, primarily in the dance science group. So today I want to talk about the dancer as an artistic athlete and how does their training contribute to their injury risk. Okay, so in Canada, more than 50% of older adolescents, so those aged 15 to 19 years, participate in organized sport. And dance was the most popular activity among female respondents to a recent survey in Calgary. But dance is a high-risk activity with high reported injury estimates. Among pre-professional dancers, the prevalence of injury has been reported to range from 80 to 100%, depending on the company, how injuries are defined, and how injuries were registered. In pre-professional ballet dancers, the incidence rate of injuries, so the number of new injuries over 1,000 hours of training, was 4.7. So this means that over 1,000 hours of dancing, a single dancer may experience up to 5 injuries. Training load has been identified as a risk factor for injury in sport. But what is training load? Training load is the volume, intensity, and frequency of training. Essentially, it tells us how much and how hard somebody is working. Now, how can we measure training load? Well, first we can have external measures of training load, and these are objective and typically sport specific. So some examples include the total distance covered, such as in soccer or football or rugby, the number of accelerations and decelerations, the weight that is lifted, such as in powerlifting or Olympic weightlifting, and the power output on a cycling on a bike. We can also measure training load internally, and these can be objective, such as the heart rate response and blood lactate. And it can also be subjective, using something as a rating of perceived exertion. Now, it's important to note that for some of these measures of training load, we can use some of the most recent developments in wearable technology to help capture some of these metrics. But why is training load relevant? Well, it's relevant because we want to achieve our optimal performance while decreasing the negative effects of training. And those negative effects include overtraining and injury. If we train too much and do not have sufficient rest and recovery, our performance will decline and our risk for injury may increase. On the other hand, if we train too little or have too much rest and recovery between sessions, then our performance may not improve because the physical training that we undertake does not meet the threshold for improving performance. So this training load performance relationship is based on dose and response. So I mentioned that training load has been identified as a risk factor for injury in sport. And this research has primarily been done in team sports, with more than 85% done with athletes over the age of 18, and more than 90% with male athletes in soccer, rugby, and Australian rules football. But what about dancers? Are dancers athletes? Can we consider them as athletes? Well, yes, dancers are athletes, but they fall into a unique category of aesthetic athletes. There are some key differences between the sport athlete and the artistic athlete that doesn't permit us to take the evidence on training load as a risk factor for injury in sport and apply it directly to dance. So what are some of these key differences? Well, firstly, dance incorporates artistry, athleticism, and athletic elements. In dance, the appearance and the quality of movements matter just as much as the ability to jump high, leap big, and twirl multiple times. Dancers often begin their training as early as age 3 and commit to pre-professional training no later than age 15. So they demonstrate what we would consider early sport specialization. Pre-professional training signifies a commitment to ballet, which involves auditioning for entrance into a vocational program where the hours of training can exceed 30 hours per week. Unlike sport, dance is heavily influenced by culture and tradition, and methods of instruction are passed down from earlier generations. And finally, there are prevalent cultural values in ballet where a specific body type and composition is selected for, where perfectionist qualities in dancers can arise from their ballet instruction and the social environment that they're in, and the fear and avoidance of pain and injury is commonplace in this unique population. So for these reasons, it's not realistic for researchers to approach dance companies and vocational schools and tell them that they are doing too much based on what's been found in sport. Because without research evidence and consideration for the cultural influence on ballet training, change will not take place in the studio. So to fill the gap in the literature that underserves adolescent athletes, female athletes, and non-team sport athletes, I am interested in first exploring one of the training load pillars and then using findings from sport research to inform training load injury research in dance. Based on previous systematic reviews in dance, only 2 risk factors for injury have been identified with high levels of evidence. However, evidence for dance exposure as a risk factor for injury is currently inconclusive. Although dance exposure makes up one pillar of training load, it is still important to investigate in the context of the elite adolescent ballet dancer. So to understand how dance exposure was related to musculoskeletal injuries, we recruited 104 pre-professional dancers from a vocational dance school here in Calgary. The majority of our sample was overwhelmingly female with a mean age of about 15 years. We followed these dancers over 40 weeks of dance training, which makes up 1 academic year for them. Each week, the dancers reported their weekly dance hours, so how many hours they spent in class, in rehearsal, and in performance. Dancers also reported their weekly injuries using a dance-specific questionnaire that was developed by the Oslo Sports Trauma Research Center. And they used 3 definitions of injury. So they reported, self-reported physical complaints, medical attention, and time loss injuries. Now, dancers also had access to a physiotherapist on site at the school. So if the dancers went to see this physiotherapist for their injuries, the physiotherapist also completed an injury report form. Over our 40 weeks, we had a very high response rate and great engagement from our dancers. So what does their training look like over the year? So on the x-axis, we can see the month of the academic year, starting from September, going until the end of June. And on the y-axis, we can see the dance exposures, the number of hours that they're training. So overall, this is what their pattern looks like. We can also break this down into their class hours only, into their rehearsal hours, and into their performance hours. Now, a couple interesting things here. We can see 4 peaks in the orange and in the yellow. That's their performance, and that indicates their 4 performances throughout the year. We can see that even though they had a spike in performance, their class hours more or less remained stable. We also see some dips in their total exposure hours, and these correspond to their breaks in the academic year, so their Christmas break and their spring break. So what did the injuries look like throughout the year? Over the 40 weeks, we had the dancers reported 871 physical complaints. So it's important to note that these were not mutually exclusive. So if a physical complaint was reported in week 1 and it was still bothering the dancers in weeks 2, 3, 4, it was also reported there as well. Of these 871 physical complaints, about 40% resulted in self-reported time loss, about 68 resulted in seeking medical attention, and about 23% were reported for the first time. Now, I mentioned that the dancers had access to a physiotherapist on site. So of these 590 self-reported medical attention injuries, the on-site physio only saw 20% of those. So that's telling us perhaps that maybe dancers are seeking care elsewhere and not necessarily at the physio on site. So how do the injuries compare to the dance hours? So again, we have our gray mountains once again looking at their total hours. And because we used several definitions of injury, we'll look at those now. So in white, we have our all physical complaint injuries. In orange, we have our medical attention injuries that were self-reported. In yellow, we have time loss injuries. And in green, we have our first report injuries. So overall, the pattern of injuries follows the pattern of exposure. When their hours decrease, so do their injuries. We see a couple injury spikes. Typically, injuries will spike not during the same week of high training, but 1 or 2 weeks after. And we see that in the month of May. And we also saw quite a few first report injuries at the beginning of the year. And that's when we first started our injury surveillance system. So what are some of our biggest takeaways from this? In a pre-professional dance program, we see that the hours of training in their typical week vary, and dance-related injury estimates are high in this population. So overall, as dance exposure hours increase, so do self-reported injury estimates. Now, where do we go from here? My future work is to investigate training loads, so not just the volume of training, but also the intensity and the frequency of training in these dancers using wearable technology, and to compare that to their injury rates to see how that relates. So I would like to thank Dr. Sarah Kenny as my supervisor and my supervisory committee. I would also like to thank all the undergraduate and graduate dance researchers with the Sport Injury Prevention Research Center, the Alberta Ballet School, and Momentum Health for their collaboration and partnership with the Sport Injury Prevention Research Center, as well as my funding sources. And here is how you can get in contact with me if I don't get a chance to answer your questions today. That's all I have there.
Excellent. Thank you so much to both Valeriya and Julia. I will share my screen again. So now we'll move into the question and answer period. So if you have a question, there's a few ways you can ask. So in the participant box, you'll see a place where you can raise your hand, and then I can give you the opportunity to speak if you'd like to voice your own question. You can also type your question into the chat, or you can type your question into the Q&A box, and I'm going to do my best to monitor all three of those. So we'll open it up for questions now. So I'm just reopening my chat window. All right, we have our first question in the chat is for, or in the question box is for Julia. Question is, how do you think the transition to more online and remote learning and working as a result of COVID-19 can help with future work in exercise prehab for cancer survivors?
Thank you so much, Britt. Absolutely. So with COVID-19, of course, we have transitioned all of our working and delivery of exercise programmings to online. So as part of the Health and Wellness Lab and the ACE program that we have, the Alberta Cancer and Exercise Program, which is a evidence-based program that's implemented here in Alberta and soon to be nationwide in Canada, we've pivoted all of that to online. And we've learned so much about what that looks like, what participants want, and how can we support people through online delivery. Specifically with exercise prehab, and what we learned with the physical assessment not being feasible prior to the surgery, we now have the tools and tips and tricks we need so that we can support patients and survivors through remote and online assistance. So that in-person assessment doesn't have to be done in person. We can now take that virtually remote, and maybe it does take place via Zoom or via phone call, but we know now how and in what capacities and what the logistics kind of look like in order to support people online. So specifically looking at how we can move these assessments and move that support to online, and exercise prehab would absolutely be Zoom or phone call or whatever method the participant prefers. And we know that it works and that we can support them that way. Thank you for the question.
That's fantastic that your research can continue and that support can also continue for those cancer survivors. Fantastic. Our next question is for Valeriya. So you mentioned that reported injury estimates are high in dance, but how does that compare to other sports? Do you find that they're higher, lower, or about the same?
Yeah, that's a good question. So injury estimates in dance are actually higher than those in other aesthetic sports like gymnastics, where it's about 1.5 new injuries per 1,000 hours, and in figure skating, where it's about 3 new injuries per 1,000 hours. But injury estimates in dance are lower than like contact sports and team sports, where like in professional hockey, they've reported about 6 injuries per 1,000 hours. So yeah, it's higher than some, but lower than others.
Yeah, it's definitely a lot higher than I would have expected, but that's just from my own experience as a very amateur dancer. So next question is actually for both of you. You both talked about definitions. So Julia talked about definitions of exercise and versus movement. And Valeriya, you talked about the different injury definitions. Why is it important to set out those definitions in your research, and how has that supported your research?
I can go first if you'd like, Valeria. Britt, that's an excellent question. Thank you to whoever asked that. Particularly in exercise oncology, it's so important because after all, we are trying to encourage movement and just this idea of getting people to move more. And particularly if we narrow the scope a little bit and look at head and neck cancer patients specifically, or just cancer survivors maybe more broadly, these types of definitions actually come into play for actually getting them to move and for that behavior change. And so one of the questions that we asked our participants during interviews were, what term do you prefer? Do you prefer exercise, physical activity, or movement? And they were like, well, what's the difference? And then we kind of explained it to them. Well, exercise is defined as more structured, physical activity is any movement, and then movement is just simply moving your body. Which of the following do you feel is just the less intimidating and kind of encourages you to move? And for a lot of the patients, they found, well, you know what? Movement and physical activity is less intimidating and makes me feel like I can do it at any point. And so when we're talking about behavior change and fostering these lifestyle changes long term, it's important that we can differentiate between those words, that we actually can create long time movers. So yes, I hope that answers your question. Happy to expand any more, but essentially it comes down to back to this idea of movement and fostering activity for these patients so that they can be supported in their lifestyles.
I'll jump in and give my take on definitions in the context of injuries. So injury definitions, something that comes up very commonly in dance research as well as sport research. So commonly and previously, injuries have been defined as time loss. So this is the highest burden of injury because this is where the athlete or the dancer actually loses time from their training. If we think of injuries as an iceberg, then the time loss injuries, if that's all we're reporting, then that would only be the very top of the iceberg. But everything that falls underneath are those medical attention injuries where a dancer may be seeking care, but they may not be losing time because they're modifying their classes or they're able to still participate fully. Maybe they're doing some prehab to prevent an injury. When we look at all physical complaints, these are injuries that are most encompassing and their burden could potentially be lower in that a dancer may have a physical complaint, but they do not seek care because they continue to dance through it. So the Oslo Sports Trauma Research Center questionnaire that I kind of showed there with the 4 questions is a great tool that's been developed to help us to capture as many injuries that we can, so we can estimate the true burden of injuries, because dancers and athletes are known to continue training and pushing through the pain and injuries and not always seeking care because of that fear of reporting. And this is not just in dance, but also in sport. We know that athletes will not report injuries because they don't want to be taken out of a game or a practice. So yeah, injury definitions come up often. And when we compare injury estimates across different sports, as well as different dance populations, such as professional dancers and pre-professional dancers, it's important that we're all on the same page and we're all using the same injury definitions, because the incidence of injuries for all physical complaints will be higher than those of time loss, because time loss are the highest burden, but not as many of those are reported compared to physical complaints. Yeah, thank you for that question.
Thank you. I'm going to follow that up. Kind of a follow-up question, though, is initially a separate question from Harrison, but about dancers and reporting injuries. So why do you feel that dancers are seeking help for or reporting injuries off-site from their dance studios so frequently?
Mm-hmm. Yeah, that's a good question, Harrison. So there could be some different reasons. The first one that came to mind was perhaps they already have a trusted physiotherapist that they work with elsewhere. Maybe their parents are in the healthcare industry, so they seek care from them. We do encourage the dancers to seek care from the physio on site, because that physio has been hired to work with the school because they have a dance background. They have experience with dancers, either because they were a dancer before or they worked with dancers in the past, or both. Now, the other thing to consider about self-reported data is self-reported medical attention may have also captured those dancers that reported that they had an intention to seek care, that they thought their injury required medical attention, but they didn't actually go to seek care. So that's something that we're hoping to tease out in the upcoming years. This is an ongoing study of injury surveillance. We're hoping to tease out and find out, are these actually self-reported medical attention injuries that they're seeking care for elsewhere, or are these injuries that they're just misinterpreting in how they're reporting? Yeah, that's a good question for sure.
Great, thank you. Another question for Valeriya through the Q&A. So it's interesting to learn that dance is different from sport because it is artistic and cultural. How do dancers cope with injuries that they might experience, given that dance sounds very personal?
That's a great question. Yeah, so from my experience and my work with the Alberta Ballet so far, the culture is definitely shifting in how dancers um, handle injuries and how they report them. So previously, and this is very common in professional dance, if you have an injury, you dance through it, kind of the show must go on mentality. But with these new findings in dance research and bringing it into the studio through trusted sources, there is a culture shift that is happening. But because dance is heavily based on tradition, those culture shifts won't happen quickly. Like in sport, sport adapted the training load injury risk so quickly. There's been some very interesting training load injury models that have been proposed and how we can actually predict injuries. But when we take that to the dancers and the dance studios and the dance teachers and dance instructors, they won't adapt that as quickly because they're so programmed to do what they've done before. I hope that answers your question.
That's really interesting. I think that also plays into what you're talking about before about pushing through. I think that's also very related with how dealing with injury when you're an elite athlete in any sport, really, this tendency to push through.
Yeah, absolutely.
Great, thank you. And one more question for Julia here. What other resources does your lab have for cancer survivors?
Thanks, Britt. Our lab has a ton of resources for cancer survivors. Everything from community-based is primarily what we're doing, and moving more so into the clinical setting through both my area of research and some of the other work we have on the go. That one of the main ones is this Alberta Cancer and Exercise program that I talked about, which is a 12-week free exercise program for cancer survivors. What's great about it is that it is based in the community setting, and that it's group-based exercise, but it's all individualized and tailored to each individual. And as of right now, ACE is expanding into wider, more rural areas, and that's our new study that's up and coming called Excel, which is about empowering and providing patients and survivors in more remote areas with access to ACE as well. And so in addition to that, there's a lot of research going on in pediatric oncology as well, creating and disseminating guidelines for pediatric oncology. And we've had yoga studies and everything. So in terms of what we have in the lab, it's very much exercise and wellness kind of based resources for survivors. And it's all evidence-based and available for free to patients in the community. So if you're looking to hear a little bit more about that, please let us know, or you can visit our website as well. But yeah, ACE is the main one, and Excel, which are really targeting all survivors in the community and in the rural setting as well.
That's excellent, thank you. Another question for you, Julia, coming through the Q&A box. First, they want to thank you for your fantastic presentations. And Julia, for you as a certified exercise physiologist, what was one or some of the things you learned through your study that you may be able to translate to the other programs in your lab or into your PhD program of research?
That's a great question. There are so many things that we learned, and specifically as a CEP, I feel like I'm always coming back down to this theme, but how can we support participants and survivors to just move more? And as a CEP, a lot of our training comes from, the principles of exercise and progressive overload, and how do we make strength gains and endurance gains and aerobic gains, and a lot of our training comes from that perspective. And I think by being able to interview these patients and participants and being able to see the psychosocial side of it as well, and coming from a behavior change background as well, I think one of the most important things is understanding, yes, these are the components of physiology, and this is what we know from a research and scientific standpoint, but from the participant and what they want and the behavior change side of things, like how can we empower you to move more in a way that works for you? So With head and neck cancer specifically, there's a lot of physical and psychosocial trauma that comes along with their treatment and diagnosis. These patients are left with impairments to being able to eat and chew and swallow and sometimes hear and smell. And these are a lot of side effects that translate over into our mental and emotional well-being. And so when it comes to exercise, a lot of these patients may not want to go out and move in a gym and be in a structured exercise program, and maybe self-conscious of some of these side effects as well. So how can we support patients in a way that makes them feel good? Not what the textbook says. Of course, apply those principles from the textbook and from our research, but at the end of the day, like, what makes them feel good? What is a way that they can move, and how can we support them that way? So I think that's one of the biggest key things that I learned and continue to do, and will definitely translate over into my PhD program of research, which will also continue to explore the patient voice and their perspective.
Great, that actually perfectly segues as well into the next question, because you mentioned about all of these side effects and how they're processing those difficulties. And so Helen asks, what about the role of emotions in head and neck cancer and movement and or exercise?
Awesome, that's a great question, Helen. And if I'm assuming correctly, I'll go ahead and answer, but if I'm answering it in a way that you weren't trying to get at, just let me know. But we know that psychosocial burden is a huge factor of head and neck cancer. And when we look to the exercise or physical activity research, we know that there's huge benefits for that psychosocial side of things. And oftentimes when we think of exercise and the benefits it can have on us physically and from a physiological level, those aren't things that often happen right away. But we know that with even just one bout of exercise or movement, 10 minutes, 20 minutes, or even 5 minutes, we see benefits for emotional well-being, depression, anxiety, and quality of life. And so when it comes to emotions and someone's mental well-being, intentionally vague, awesome, thanks, Helen. Someone's emotional well-being and mental well-being and how exercise can help them in that side of things, we know that when someone engages in that bout of movement, we see those acute effects right away. And then also when someone's diagnosed with cancer, that sense of control they have in their life is taken away. And exercise, physical activity, or movement is a way to help them regain that sense of control in a very uncertain and overwhelming time. What can we provide participants with so that they can feel controlled again? So that's one way of many ways that exercise can tune into some of those emotional and mental side of things for these patients.
Fantastic. Thank you so much. Well, I'm not seeing any more questions. So I feel like we're nearing the end of today's session. So I'd like to give a big thank you again to both of our speakers today for such great and interesting presentations. I'm already thinking about how I can apply your research about training load as I work on my own training, but also about just moving more. And you don't always have to be training for a goal, but really just to be moving more and how the health benefits of that as well. So thank you. Our next Lunch and Learn session will be held next month, same time, same place, basically. You can stay tuned for registration details on the Graduate College website, as well as the regular grad post emails. And if you'd like to connect with the Graduate College, our website is there, and you can also check us out on social media, LinkedIn, Twitter, all of those sorts of things. So thank you again very much to our speakers, and hope everyone else has a great long weekend.
Thank you, everyone, and thank you, Britt. Amazing job, Valeriya.
Thanks, everyone. Thanks, Britt, for moderating, and thank you, everybody, for attending. Great to share the lunch hour.